Welcome to week 4. We're making it. We just got one session left after this. And yeah, so far I've been getting great questions from people along the way. And I've been meeting with students and hearing all about their interesting projects and seeing what's going on. So it's been really wonderful. If you got any questions, please go ahead. I'm watching the chat as we go, and also keeping an eye on any hands that are raised or anything like that. Let me just see my screen is sharing properly. Great. So yeah, welcome to week 4. We're conducting outcomes analyses, and today we're not going to talk as much about peer review, but I've got an idea for how we can do this efficiently for those who are maybe sharing things with faculty or want to share their PowerPoint, their outcomes around with everybody. But yeah, so as you've seen in the last couple of weeks, we had first week we were talking about navigating TriNetX and how to begin a project. Week 2, we were looking at defining and exploring cohorts. In week 3, we started looking at comparing cohorts and propensity score matching. This week, we're going to look at those outcomes and doing some peer review. And we're going to create a poster next week from your study. These are the Bootcamp's objectives. They haven't changed, but I think you'll see by the end of today, we'll actually have started to meet all of them and have completed our overall objectives for the course. Please let me know if you don't have a TriNetX account, and if you need one, I'm happy to set that up for you. All right, so just a little callback to our earlier stuff. You can see some of the topics we covered in our earlier sessions, and today we're going to be talking about stats and outcomes. And you can see here we are in our rapid development process overall, generating our initial cohorts. And then, based on your outcomes, you might have to go back and rebuild your cohorts and change them a little bit. We'll talk about how and why when one might do that. And then if you're doing the even more rapid process, you can examine your outcomes and check them with an expert using some of our tactics today. And here you can see we are finally at the outcomes at the top of the house. We're putting the roof on our house here in our extended metaphor of building your study. Where we've got everything taken care of. We've got cause and effect order taken care of. We have propensity score matching to help us reduce confounders or complexities in our study. We've selected the appropriate analysis type. For us, it's going to be a 2-cohort comparison. And our cohorts are all really nicely built up, which is the essential component for developing a good study. Just to call back to some of the example, my worked example and what you're going to see today. Is this piece of internet clownery that I saw a couple of months ago. This is the foundation of the kind of example study that I've been running in the background. This gentleman who otherwise was providing pretty decent advice decided to get up on a soapbox one day and declare that Alzheimer's is a physician-created disease and didn't even exist 40 years ago, not even under another name. And that it's purely created by the overprescription of statins, which disrupts cholesterol, availability and formation in your body. And that is really what has caused it all, which makes no sense considering they've had what we might call these days Alzheimer's disease. They identified it in as early as 1906. In some cases, Alzheimer's had seen it as far back as the 1880s. So, definitely some craziness here, but as I said, maybe raises a reasonable point. Maybe fewer people should be on statins. Maybe we need to reevaluate. And some recent studies have started to take a look at the possibility that maybe not all the right people are getting statins, and the people who are getting them maybe don't need them, and maybe it's not really doing what it should be doing. So again, for Alzheimer's, as I've said before, it's very complicated. There's a lot of items to consider when evaluating the relative role of statins in Alzheimer's. It's not just like, statins affect cholesterol, which causes Alzheimer's. Like, it's way more complicated than that, way more complicated than I can explain. Hashtag not that kind of doctor, I'm not an expert. But things to consider are dosage, length of treatment, comorbidities, dietary considerations. Countries with more beef consumption have higher rates of Alzheimer's. You can see them go up together in tandem. Could just be a correlation, but it could also be a causal mechanism in there as well. Poor understanding of Alzheimer's causes. It's a type 3. There are multiple hypotheses. There's inflammation, beta tau proteins, diabetes type 3, all sorts of stuff. Genetics, ApoE3 and double ApoE4 variants can cause all sorts of plaques and things like that. And there's also ethical issues in conducting studies related to these things. For example, if you knew that statins would help most people with their triglycerides, and that's a more immediate danger to the person's health, is it ethical to withhold them or avoid them to protect against the hypothetical possibility of Alzheimer's? So lots of stuff to consider. As I said earlier in our course or our boot camps, there's a lot of studies that have looked at this using randomized controlled trials, but this is actually also a great opportunity to use TriNetX to take a look at some of these, because it's, number one, really hard to create the right kinds of cohorts that you might see in an RCT prospectively. And number two, there's a lot of like wild variation in these studies that can be very hard to control for, even in a meta-analysis. And also, not all reports in a meta-analysis tell you everything that you would want to know in the study. There are a number of these meta-analyses that show that talk about how they, even within the meta-analysis, could not control for other potential confounding factors, because the original randomized control trials that served as the foundation of the meta-analysis didn't report that stuff. So it's hard to tell what the result or what the relationship, for example, of ApoE4 status is to the interaction of that with the statin, because we just don't know from those studies. Even though they were done in a scientific fashion, a randomized control trial, we just don't know. We can control more of those variables with TriNetX, even though it's a retrospective study based on all the stuff we've been talking about earlier. We can take a look and see and offer a null and a positive hypothesis that statin is not associated with any changes in the likelihood of development of Alzheimer's, or that statin use is associated with a lower likelihood of developing Alzheimer's disease, as was identified in some of these studies as well. And we have a bioplausible mechanism for that, and all that stuff's really interesting. So that is kind of where we are. I want to enter back in today talking about index events just for a minute, because we talked about that last time. And I'm going to start us out in our analysis. Now, where we are in our TriNetX study is in our analysis view. What we're looking at here is the characteristics window. We already have assigned over here our, let me get my here we go. Get my laser pointer here. So, or my spotlight here. So what you can see here is we've added two cohorts to our thing. We have a group of individuals, otherwise healthy, no comorbidities that fit into Alzheimer's broadly. And we have all of our folks here who are not on, and they're not also on a statin. They've never had a statin before in their life. And we also have our group over here where we've had people who are on statins for more than 1 year. That is, their first instance of being prescribed a statin was more than 1 year in the past. And they have no Alzheimer's comorbidities. There's otherwise healthy people. What we're trying to do here is to control for that relationship between the two. Otherwise, we could look at everybody who has an Alzheimer's diagnosis and work backwards from that and see whether they had been prescribed statins. What we want to know is, do otherwise healthy people who are on statins wind up developing a problem within, based on starting anytime in the past and proceeding anytime into the future. So this characteristics window that we talked about last time looks back into the past from what we call our index event. The index event is the moment in your study at which all items are true in your cohorts. So you can see down here, I've got some people who have ibuprofen and they've never had a statin. I have people who've never had heart failure or cerebral infarction or any of those kinds of things. And what I did in TriNetX was check these boxes to affirm that all of these items are index events in my study. That is, the study begins as soon as a patient enters the moment that all of these things are true, enters the day that all of these things are true about them. They have never had a statin, and they've had a visit, and they are over the age of 45 years old. That's the day that people in cohort 1 enter into our study. Similarly, in cohort 2, the day that they're prescribed a statin, all those things, same things are true of them, but the day that they're prescribed a statin, they enter our study. Everything looks forward from that moment. But in that, we're defining and saying, looking back into the past, as far back as the record goes, we don't want to see any statins, any heart disease, any heart failure, nothing like that. So the characteristic window, as we talked about last time, looks into the past. And today we're going to look at the tool that tells us how to look into the future. So we're getting in our DeLorean and going into the past right now. And again, that index event, I want to revisit from last time. It's a little bit confusing for folks, and definitely it is. It's worth thinking about. But it's the index date for each patient within a cohort is the day on which the patient first meets all selected criteria for that cohort. And that's when we're going to look backward at the cohort. You can see over here, the day that the index event occurs, the cohort characteristics are in the past, and our outcomes are in the future. There's an example that I showed last time, and I'm happy to share this link into the chat as well if anybody wants to take a read of it. But it has a very good visual approach to displaying how to think about index events. And when different, even though you're looking at the same thing in a person's health record, different, the index event can occur at different times in their life with different moments chronologically as well. Okay, so I just wanted to start us back in on the concept of an index event because that's going to form a lot of what we think about going forward into our analysis. So I want to go back also to look at this concept called, and you're going to see this on the screen in just a minute. I'll show you where to find this. I want to look at the concept of your baseline characteristics. So this is separate from propensity score matching last time. We talked about propensity score matching. Propensity score matching is where TriNetX uses a algorithm based on a logistic, or sorry, a logarithmic blanking on the statistical test. It's a regression analysis that basically looks at how different each individual in this cohort is based on features you define. So based on their age, based on their sex, based on other diseases they have, and it assigns them a score. And it matches individuals one-to-one to your cohort based on that score. That helps us to reduce confounders and to make sure that our cohorts are balanced later. But the baseline stats looks similar but provides a different function. It's a useful thumbnail comparison of rates in the two cohorts overall. So basically, it's a t-test that compares whether you have differences in your group based on male and female. And you may, as part of your study, want to explore some of those epidemiological features of your cohorts. That is, in my no statin, no Alzheimer's disease, or my statin and Alzheimer's and no Alzheimer's disease groups, are there systematic differences that I'm interested in that I that I want to report a value on? So they're not as nuanced as your outcomes analysis is going to be, and it doesn't tell you timeframes and things like that, but it can just tell you in a big picture, number one, if you should consider propensity score matching, or number two, if you should go back to reviewing your cohorts to exclude a factor, if you're missing something, to see how different two items are from each other, or two kinds of things are from each other. You can do that. So going back to this, we are on our characteristics page here, and we're looking at the demographics between our two cohorts. And as you can see, I starred my characteristics here. For those I starred age and index, and I starred my male and female characteristics, and they've been added over here to the saved characteristics bucket. Now, what's useful about that is when I go to this screen, you can see it. I'll show you the live TriNetX website. You can find it. Here's your cohorts. Here's that characteristics thing that we were just looking at a minute ago, where you can see all the characteristics of your cohort. Here's the baseline comparison tab on the left. So that's what we're looking at. And when you see it, you'll be able to see all of the items that you starred as the characteristics earlier in this page, and you'll have an option to run this comparison. And then once you've hit that run and you wait and you wait and you wait for TriNetX to crunch all the numbers, what it's going to do is tell you whether there are any statistically significant differences between these two groups. You can see here, it'll tell you the p-value of that difference. It'll tell you your standard difference, which is super great if you want to go do something like calculate a Cohen's d of the impact of this thing, effect size of the impact of this difference. It'll give you your patients in that cohort that were pulled to make this evaluation, and then the differences between the cohort, the percentages. This is extremely useful here. You can also see whether it's going to give you a ballpark number, whether there are enough people in your cohorts with this outcome ever in their whole life to allow you to see whether this is going to be a worthwhile outcome to run on your study. And so here I can see that there's a statistically significant difference between my two groups based on their Alzheimer's outcomes. And that means that I feel a little more confident that when we go to my outcomes view in a couple of minutes and I run the differences between the two cohorts, we're going to see something that's interesting and potentially statistically significant and valuable. It's a very small number of people. You can see it's 0% of the cohorts generally, but it's there. And 3,100 people in one cohort and 2,400 people in another, 2,500 people in another cohort is nothing to sneeze at. I wanted to make you aware of that tool, and you can see it, as I said, very easily in your component as well. You can also, by the way, add things. If you didn't find something in your characteristics group, but you want to add them, you can use this function here to add diabetes or something like that as well. If you wanted to compare at a baseline your two cohorts. So let me know if you have any questions about that function. I think it's really useful for getting a sense of whether your study is going in the right direction or not. I'm happy to read to answer any questions in the chat as well. But now we're moving on to this is the thing. This is the moment we've all been waiting for, the time we've all been waiting for 3 weeks to look at outcomes. We're gonna start by looking at the exploring outcomes function. And exploring outcomes is not really suitable for your final analysis because, once again, it doesn't have time constraints and it doesn't have some of the additional statistical tools, but it's a great way to find unexpected outcomes for your cohorts. Now, the found cohorts, the items that you find, the outcomes that you find in there can easily be included in your final analysis. Let me show you how. So the Explore Outcomes window is going to be on the left-hand side in here. So you've got your characteristics where you can look into the past. You've got your baseline comparison statistics where you can look and compare the two groups statistically and get a nice p-value to compare the two groups. You've got your balance cohort function over here. And that's where you can do your propensity score matching to determine if you need to balance your two groups. And then over here, you've got your explore outcomes function, right? That's really right in the good spot. So again, you can actually set, I was incorrect, you can set this time frame here to say, I want to look at outcomes for the people. I don't want to specify a particular outcome. I want to see all outcomes for the people in these two groups within, in this case, any time, but you could look at it in a 5-year bracket or a 3-year bracket. So what's really useful about that is you can go back to the future. You can go as far into the future as the person's record goes and look at what happens to the people in your cohort to see what might be of interest in your analysis. That's actually going to bring back up our doctors don't pay money late heuristic. Remember, I know medical students and physicians love heuristics. One of the first years came up with this. Demographics, diagnoses, procedures, medications, and labs. Doctors don't pay money late. Those are the things that you can look at to see what kinds of outcomes and differences you might have in your folks. So when you have run your time, once you've selected your time frame and you hit the run button on this, you'll be able to look at things like diagnoses. When you look at the diagnosis setup with ICD-10 codes and all that, you can actually choose a really nice feature here where it says, you can, number one, search for any particular outcome that you might know you're interested in, but you can also divide them by acute and chronic. So in my case, I'm probably not going to be interested in a lot of acute outcomes. I'm going to be interested in other chronic diseases I missed. Maybe that might be confounding my analysis of Alzheimer's disease. There might be something going on that I'm not aware of. And so this tool can be really helpful in spotting some of those things. You can see I also looked here for Alzheimer's disease because I wanted to find it quickly. And you can see that it shows up, this is the reason there are fewer people in here than in our baseline comparison is now I've introduced a time bracket to this function that only looks at a couple of years pre and post our initial index event. So yeah, you can search for stuff, you can find it. And once you star it, you can also, it has the signal tool that we introduced a little while ago. If you all recall, the signal tool is really useful for helping to see whether there's, the platform will statistically weight the differences between these two groups, and then give you an idea of whether those differences are significant based on the number of bars, like your cell phone bars, that you might have in there. And then you might choose to star that group and look at it. Now, as I said in an earlier video, this is the same as your characteristics. It is probably not a good idea to star the top level group. Like, for example, Alzheimer's exists in a category called G30 to 32, other degenerative diseases of the nervous system. If you select that, you're going to get a bunch of other stuff in there that you may or may not be interested in pulling in. So it's better to go further down into the hierarchy and pick things that are at deeper levels. And when you do that, it'll add them automatically. Anytime you star one of these, it automatically gets added to this bucket over here called saved outcomes. In a lot of ways, this is very similar to how we do the saved characteristics function, except you'll be able to use these later when you look at your outcomes. It'll automatically give you access to those. So as you're looking through and you're like, oh, you know what? I do want to see, in addition to that, whether there are differences in other kinds of demyelinating diseases of the central nervous system. I'm going to check that one too. Then it'll add it to the list and you'll be able to really quickly access it later. I'll take you through that in just a moment. So now that you've had a chance to explore your outcomes and see what's in there, we are finally ready to run our outcomes. Hours and hours. I'm like 4 hours into talking about this stuff, and we're finally able to get to our outcomes. We're going to this brings together all of the work we've done so far, our cohorts, our propensity score matching efforts, our outcome discovery, all of it's getting brought together to this moment. But you got 5 decisions that you have to make as you work through this. There's actually more than that, but these are the 5 most important ones. So I'm going to take you through them and introduce you to some of the key things you have to think about and logic and reason through. I mean, some of this you can actually find in your recipes when you're looking at studies. They'll tell you whether they did propensity score matching or not. They'll tell you about the time frames they used and all that kind of stuff. But you have to ultimately be responsible for reasoning through which of these items are going to make a positive or negative impact on the accuracy of your analysis. So the first decision you have to make is obviously propensity score matching or no propensity score matching. And so when you're in your outcomes function, I'm just going to show you the live site really quickly. You'll see the box right here. First thing you see is going to be this little subset of boxes under select balance preference. So when you do that, in this case, it defaults to propensity score matching being off, but you can really easily select the other box to turn propensity score matching on. For those who I've talked to in the past, I kind of recommend starting with it off and then turning it on later, so you can collect both. What that'll do is help you determine whether the loss of the number of people in your study, the loss of the N that will occur when you introduce propensity score matching, whether that's actually going to be valuable for you later on, whether it's worth the loss of N to get the outcomes you get. If they're actually really similar and statistically not that different, then I suggest providing both in your study and letting people know that that's the case, that you are giving them both to give them a good, honest vision of your data, but that big or small, both cohorts are have equal kinds of outcomes. So that's decision 1, propensity score matching or not. Decision number 2 is going to be your time frame. Once again, how far into the future are you going? One thing I often warn people about is the further, we're going to talk about this actually, when selecting the time frame of your study, you really have to think of a couple of things. One is, depending on the study, the longer your time frame, the less likely that your outcomes are related to the event. So even if it's something fairly major like cancer, after 5, 7, 10, 15 years, time has worn on, other stuff is going on with your patient. They were in their early 40s when your study started. 15 years later, they're in their mid to late 50s potentially. And they're in a different place in their life and their health span, right? So you need to think about that as you're selecting your time frame. how long out do you want to look? On the other hand, picking too short a time frame means that you might miss outcomes that are actually important. And that could mean something like, for example, the long-term cumulative effects of a drug may result in cancer 15 years down the line. If your study stops at 5 years, well, that's great temporally to keep those things related, but it actually might disguise or hide the long-term cumulative impact. And as everybody knows from looking at research these days, it can be that you follow people for a couple of years and they don't exhibit disease, but it's only many, many, many years later after they've left their youth and into further into their health span, when they're experiencing chronic disease, that some of these things come out and become more complicated. So to determine the right time frame, you really want to consider the type of disease or condition. Obviously, things like cancers can take longer to impact people than things like infections do, but some conditions can impact people for years and can have years and years and years of outcomes on a person's health that you might be able to see in other ways. So that's something to think about and to use your knowledge and expertise to consider and reason through. Second, consider existing research. What kinds of timeframes are used in other studies? For example, when they did a clinical trial, did they do it for 5 years, 7 years, 10 years, 1 year, right? Those things tell you a little bit about what other experts may think are relevant to your study in terms of the time necessary, the time frames in which they would expect to see these outcomes based on their clinical experience. So you can, if you're absolutely lost, you have no frame of reference, there's no studies to help guide you, nobody has any idea, you can always start with your lifetime analysis. Because with TriNetX, the beauty is you can run this as many times as you want. You can start with a lifetime analysis and use the Kaplan-Meier tool that we're going to talk about in just a couple minutes to help you see when you might want to focus in on the person's lifetime. So you might see, using the Kaplan-Meier tool, that your patients everybody has the same outcomes for 3 years, 5 years, they're the same outcomes. 10 years, they're the same outcomes, but at 15 years, you start to see the curves of people's illness starting to diverge. And that could be a really useful way to then go back and bracket your time span or open your time span up as much as you want. If you go back and you see almost everybody got sick within 3 years, well, there's no point in including 10 years of study. That just waters down some of your results, and you might want to set your time frame back to 3 years in order to capture all the people that you're fairly certain are sick from the thing you're looking at. All right, so decision number 3, we talked about, I brought back index events, but I want to, it's funny, usually we check all the, I don't want people to just automatically check all the blue boxes on a study, on their studies when they're doing this. Because not every component of your cohort characteristics is part of the index event. Like, you might want people who maybe had an ibuprofen, but you don't care that the study starts on the day they had that ibuprofen, because what you really care about is some other feature that you've defined in your cohort. So you don't have to select everything as part of your index event that defines your cohort. You can have a subset, and that actually can make a big difference, because you can have people enter your cohort. People who will have developed Alzheimer's could enter your cohort, even if you don't check that, even if you don't want the study to start when they have been diagnosed with Alzheimer's. So lots of ways to deal with that. Or, for example, I might want to have people over here who are on statins, but the study doesn't have to start the day they had statins. It could start 6 months before, 6 months after, 10 years before, 10 years after, as long as sometime in their record they have a statin. That's what happens when you don't check the index event. It means just someday, at some point in their life, they have that event. If you check the index event, that's when it becomes part of when our study starts. So something to think about. I know that can be a little confusing. I'm happy to help everybody think that through as they go. Another feature is the outcomes window. So this is where we're going to make decisions 4 and 5. And we're going to see this in a little more detail coming up. But the outcomes window gives you a couple of options. First, do you want to have your outcomes run individually or pooled? I'm gonna tell you what I mean about that. So this is a view of our outcomes window where this is where in the TriNetX platform, let me just show you. As you set up, you can see here, I've got my time window all set up. I've got my my index events all programmed. You know, you could, as I said, I could remove this from the index events or I could keep it. Hope that didn't mess up my last thing. But what you also get is this opportunity to define as many outcomes as you want. You can see here, I've got Alzheimer's in here. I've got another one with demyelinating diseases. I've got another one with any kind of degenerative disease that you might think about. And I can have as many of these as I want. I got another one, unnamed. I'm actually gonna, should probably name this and call it mortality. Mortality. And you can have as many of these as you want. That's one of the beautiful things about this part of TriNetX is you don't have to like run one outcome at a time and run them again and again. You can run them all together. And that winds up being really useful for you later on. But it, as I said, creates this dilemma. Do you want to have an individual outcome or do you want to pool your outcomes? So I put all of my neurodegenerative diseases that I'm interested in one bucket in this pooled outcome version. And over here, I have my individual outcome. And this can make a real big difference in terms of what you are looking for, right? Like it may change your numbers dramatically. It could be that Parkinson's outcomes are very different from Alzheimer's outcomes. And so by putting those together, I'm actually blurring which one is getting impacted more by the statins. Versus over here, I might actually be losing out on people who are also experiencing neurodegenerative disease of a different type that's related to the statin as well. So it's a trade-off, and there's no reason you can't do both. So it's just something to think about. Also, when I talked about earlier, saving those outcomes, this over here is, let me see if I have any saved outcomes actually. Yeah, so you can see over here when I saved that item with the Alzheimer's disease under my explore outcomes function, it got added to this bucket. So I can really easily just add the Alzheimer's here. So if you've got a bunch of ICD-10 codes and you're tracking a bunch of things, this saved using the saved outcomes function from your, let me show you over here, from your explore outcomes window, you can see my saved outcomes over here. Using this function really makes it easy to build your outcomes functions down here. So that's a decision you have to make, pooled or individual. It's going to impact your numbers one way or the other, so you really should have a justification for why you did one or the other, or did the other. Your fifth decision that you're going to have to make when you do this is on your analysis tools. So this is my favorite window. This is where you can choose the kinds of tests you're going to run on your outcomes. So you've got your measures of association over here. These are your risk ratios and odds ratios that we're going to look at in a sec, and also your Kaplan-Meier analysis. And we're going to talk briefly about a number of instances later, but it's not that relevant to this particular study. And there's only a kind of finite number of use cases that use it. But for almost everything you're going to run, you're going to want to know your measures of association and your Kaplan-Meier analysis. And one decision you're going to make after I've told you about what those functions are and what they do is whether you want to exclude patients with the outcomes prior to the window. So in this case, if my outcome was Alzheimer's, I probably don't want people in my study who already have been diagnosed with Alzheimer's at some other point in the past, right? It's going to really muck up my numbers a little bit because it's something, especially in this case, you can only be diagnosed with once in your life, right? So I don't want people to be, I mean, I guess you could have multiple doctors diagnose you, but generally it's a kind of binary condition. You either don't have it or you do have it, right? So, you know, we probably don't want to include those people in here because they may, even though they may fit all of our other characteristics, they may already have developed Alzheimer's before our study starts. That is, before they were given a statin, they may have developed Alzheimer's before some other characteristic, some other thing was happening to them. And so we're probably going to want to exclude them. So there are other situations, however, and we're going to talk about that briefly, where you may want to not exclude people with outcomes prior to the window. So one example might be fractures, right? If you're looking at a study of why some people or how some people have developed fractures, or what happens to them, you don't necessarily want to eliminate everybody who's ever had a fracture before. And similarly, you may not want to eliminate everybody who's ever had a surgery before if you're doing a study on surgeries. Because if you do that, you're going to, number one, artificially constrain your pool. No reason to, have, because the person had a toenail surgery 10 years ago doesn't mean it's going to predict anything about their outcomes on this particular surgical procedure that you're interested in looking at now, unless you have a reason to believe that that's the case. However, things like cancer, having had cancers at some point in the past is a predictor of having cancers in the future. So you may want to exclude anybody who had a neoplasm of the particular type you're looking for in the past, because they're going to muck up your numbers. So those are your 5 decisions, but once you've made those decisions, you can go up to the top and hit the run button. Hallelujah, we made it, right? We're at the outcome. And now we can start looking at our outcome stats, right? This is the good part. This is the numbers. This is very rewarding, I think, after you've done all this hard work and thinking and reading and rereading and like sitting there trying to cogitate about what the relationship of these things are. You are now ready to look at it. So I'm going to take you through 4 types of stats this thing is going to produce for you, and each of the subtypes that it's going to produce as part of these tests, the suite of tests that it runs. It's running, in a lot of cases, R in the background, which is great. It's a well-known statistical package that is free and open source, and they run it, and it produces pretty solid outcomes. It's used by most professional statisticians these days. So we're going to look at the propensity score matching results for your outcomes. We're going to look at the measures of association, which are probability. What are the odds and what are the risks that people might encounter when dealing with these conditions? And then we're going to look at Kaplan-Meier curves, and that suite of tests relate to time and how many people and when these events occur to those people. And then we're going to look briefly at a number of instances, though I'm going to just tell you about it because it's not that useful for us. So propensity score matching, we talked about it last time, how to do it right, how to do a good job. It's going to balance our cohorts so that they're not statistically significantly different from each other. Not that they're random, but that means along the variable that we're looking for, let's say the number of male or female participants in one cohort or the other, they're going to be indistinguishable from each other along those lines. They're going to be randomized along that line. So these density graphs aren't that useful for us. All they tell you is, like, you can see over here that the cohorts, the number of the score that they were given for similarity was different. You can see that there's a divergence between these two groups. The purple of cohort 1 and the green of cohort 2, or the teal of cohort 2, are not on top of each other. However, following propensity score matching, you can see that they follow each other perfectly, which means that beforehand there were differences before them, and these curves look super different, right? One looks like, I don't know, alligator teeth, and one looks like a big parabola from like middle school. And this one over here, they're identical. It's two little mountains, there's a couple mountain peaks, right? So basically another way to think of this is cohort 1 has been made to look more like cohort 2 so that we can run an apples to apples comparison of these things. But what's useful is on your study, it will, after you've completed your results, I'm just gonna pull mine up in the background over here. What's really handy is it'll allow you, number one, to go back and it'll produce a p-value and just trying to open up the live version of this. It'll produce a p-value and a standard difference for the two groups so that you can get a sense for whether the propensity score matching was valuable. In this case, beforehand, the groups were all statistically significantly different between their across the different groups. You can see between age, male and female, male and female. But after matching, you can see that they're all statistically significantly random, not random exactly, but they're not alike. There's no likeness about them, or no difference between them statistically. So that's great. And there's no real meaningful standard difference between the two. So their standard deviations are set. That's really good for us. That means that our cohorts were successfully matched in a way that provides us with a more accurate or more apples to apples comparison between our groups. And that's what we want. So you can see after matching and before matching, and you can see our before cohort and our before matching and after matching for our groups are quite different. This takes us to our first tool, the measures of association, which is probability. So when you see this on your screen, once you've run your results, you can see over here, this is the main kind of window that'll tell you something interesting. So you'll find actually, if you run your study several times, your numbers here might change. Your patients with the outcomes, and even your patients in the cohort, they might stay the same, but your patients with outcomes might change because depending on the propensity score matching and who was randomly selected from the pools, you may have slightly more or fewer people who fit your study's characteristics if you run these studies multiple times. But what you'll find here is your patients, total number of patients in that cohort. So this is all people in cohort 1 or cohort 2. And these are the people with the outcome. That is who actually had Alzheimer's at the end of their lifetime in the study. And you can see over here, yeah, here's number 2 per group. And you can see the risk ratio between the two. So risk ratios are super easy to calculate. It's the total, the patients with the outcome divided by the total patients in the cohort. It's just this divided by this produces 0.343. If you've got a calculator, you can divide 2547 divided by 741,966, and you'll get roughly 0.343%. So that's 0.00343 for those who are doing math. And you'll see over here, there you can see that those are pretty straightforward stats. Where things get interesting on here is TriNetX will also run for you a z-test. So it's z-test, and that z-test is going to be included in your risk difference profile. So the risk difference is the risk posed or that occurred in group 1 minus group 2. So it's actually quite straightforward. It's just 0.343 minus 0.214 gives you 0.129. And what's nice about that z-score is it'll give you a 95% confidence interval, meaning based on these values, what are the odds that the value is between 0.129 or is 1.29, and 95% confidence is it's between 0.112 and 0.146. The z-test, which for those who are familiar with a t-test, a z-test is similar, but it's more robust against large numbers. Like a t-test, the t-table, 14 would be a really, really, really challenging number. Not really, really, but you could have a number so challenging that it's actually quite difficult to calculate using a t-test. So they invented a z-test that's more robust against larger numbers, and it too produces a p-value that's the same as the p-value we've always seen. In this case, our statistical significance is below 0.05, and in this case, it's 0.0001. That's great. So that means we have a statistically significant number there. Also, it will produce for you a risk ratio. This is extremely valuable because when you hear people say like, oh, somebody is twice as likely, or in this case, people who have not had statins, who have not been on statins, are 1.61% more, or sorry, 1.61 times more likely to get Alzheimer's than people who aren't on statins, who are otherwise healthy. It's really a simple value here. It's just cohort 1 divided by, the risk of cohort 1 divided by the risk of cohort 2. But it's a pretty standard formulation that's used throughout public health. And it'll be really valuable for you to be able to say, look, it's a 1 point in this, even in this very small cohort of individuals, they're 1.6 times as likely to experience those negative outcomes. 160% is likely. Similarly, it will produce your odds ratios. I'll leave you here with the definition of an odds ratio. But basically, it's the patients in cohort 1 divided by the patients in cohort 2 with the outcome, divided by, with patients in cohort 1 without the outcome, divided by patients in cohort 2 without the outcome. And it produces, in this case, a similar number, though these the odds ratio and the risk ratio can be quite different. And it's really useful because that's the odds of a person developing in that cohort, developing a condition like Alzheimer's, or developing Alzheimer's in that case. Here's your, also, this is the most visibly obvious thing, is your risk of outcome chart. And I strongly recommend redrawing this in the future, because look at that. I mean, that is really not going to look great on your poster, right? If something's 160% the value of another thing, well, you might want to just redraw it, right? With maybe an x-axis of between 1 and 2%. That'd be clear to people, that your axis is really compressed. But in this case, there's no point in using this graph like this on your poster, for example. So next week, I'll show you how to redraw this to make it more usable and publishable in your work later on. But you can see it's basically just your risk ratios graphed against each other. Some notes. I have talked with a lot of epidemiologists and clinical biostatisticians and people like that, and they're like, but 0.13% is clinically meaningless. That's like 2 people a year. And I'm like, yes, that is true. But at the population level, it's not clinically meaningless. It's actually a lot of people, right? It's a huge number. Just to put in perspective, if these numbers held true, and it was 0.13% is the difference between the two groups, 0.0013 times the, let's just conservatively say 13 million statin patients who might in the entire US population fit our very stringent criteria. This would allow us to lower, if this was the case, that they would benefit from statins, that could lower the risk for 16,900 people across the United States. That's a lot of people. Even if some of our conservative estimates were true, I'll take 8,000 people, right? That would be great if it was half of what we think it is from our numbers here. That's still a lot of people. Just to put further in perspective, the lifetime cost of Alzheimer's care is estimated to be about an additional $400,000 per person in the United States. So think about that, 16,900 times $400,000 per person is $6.76 billion a year we could save. I mean, I don't like to put people's lives and comfort in relationship to dollars, but that's a lot of money. We could do a lot of good with that $6.76 billion, right? So total Medicare annual costs for Alzheimer's are something on the order of $320 billion. So we could reduce costs by about 2%. Once again, 2% doesn't sound like a lot of money, but if I say $6.76 billion, well, that is a lot of money, right? So just something to think about as you're thinking about how small 0.13 is at the clinical level, but how big it is at the population level, how much of a difference that can make. Also, by the way, most Medicare plans and most health insurance plans cover 100% of generic statins. So it's really a low, no cost to the patient. If there's no other reason, now you all are physicians, I'm not, but if there's no other reason, it might be worth putting people who are maybe relatively low risk on a relatively low cost drug. It might just be beneficial for people. I'll leave that to physicians to discuss, but with the knowledge that we could actually save a lot of money, save a lot of lives potentially. And bearing in mind, of course, these are otherwise very healthy people who don't have hypertension, don't have hyperlipidemia, don't have blood pressure. They're on statins for potentially a bunch of other reasons. But it's not exactly the natural group of people out there. If we took our study back and we said, you know what, we're not going to control for anything. I'm going to just, everybody in my pool who's on a statin, let's take a look at them. We would actually potentially even find that it's maybe better for people than we even would know based on these data. So just something worth thinking about. I won't harangue too much more about that because we got still a little bit to cover today. But it's something to think about as you're considering your own analyses. The difference between population and clinical outcomes. So Kaplan-Meier and time-based tests. Let's segue into one of our other great kinds of analysis. So when you run your analysis on your screen, just to show you, bring back my TriNetX now that it's rerun itself. You can see here, here's my Alzheimer's disease thing on my outcomes/results page. You can see here, as I was saying, my numbers are slightly different than they were yesterday, but statistically it's the same. So instead of being 1.601, it's 1.59 today. I could run it again and we get maybe 1.61 or something, 1.62. So you'll see those are slightly different based on the propensity score matchings, selected population. But right below that is going to be our Kaplan-Meier curve. I'm going to take you through it on this screen. Basically, the Kaplan-Meier curve is it's very confusing because they call it a survival curve. Completely the most confusing thing for physicians in the world, because I've talked to very, very experienced, excellent physicians who've never encountered this tool, and they, understandably, as intelligent people, would assume that survival means living or dying, right? How many people are alive at the end of my study? But survival in this case is more of like a statistical, epidemiological, like engineering term. You can think of more like time to event. How long until this thing happens to the person? So survival does not mean mortality. And I just want to say it again, survival does not mean mortality in the Kaplan-Meier context. It refers to the absence of a particular outcome in a group of patients. The way I think of this is if you had a bunch of like little wooden pegs lined up in a row, or like dominoes lined up in a row, every domino you knocked over is no longer surviving, right? You went down the row and you knocked each one over. If you stopped at 5 and you had 10 left over, then your survival number is 10. Those are the people to whom that event did not occur. It occurred to 1/3 of your 15 dominoes. And here it'll tell you, here are the number of patients in the cohort, here's the patients with the outcome. But what your previous analysis didn't tell you is how long it takes for that event to unfold. And as I said, time-temporal relationships are really important. But what we know is I set this to be a lifetime, because Alzheimer's can take years to progress. Some people it shows up late, some people it shows up early. There's a number of factors that impact that, including genetics and other kinds of variables. So we wanted to let it happen over the course of a person's lifetime. So we see here from this that the survival probability, that is the number from this is where it gets confusing. A survival probability of 100 means nobody has developed Alzheimer's yet. And the bottom of this graph, you can see that's the survival probability, where this is actually 0 and this is 1. It's extremely confusing, right? Because you're counting down from 100% of the people. If you had a line like this, your number would decrease linearly, in this case, from 100% of people not having the outcome to 100% of the people having the outcome. It's super confusing, but you'll see in a minute, it actually can be very valuable. This on the bottom, though, this days after index event is actually very easy to understand. Based on how long you set your time window in your TriNetX study, that's how long these go on for, this time frame goes for. So in this case, it goes out as far as 7,000 days, which is like 18 years for most people for the record. And you can see that for most of that record, these numbers are like right on top of each other. However, once you start getting out at about 5,000 days, if 365 days times 10 years is 3,650 days to get to 10 years, see about 10 years, they're getting similar. But as we get out to 20 years, you can see this purple and this green over here start to diverge just a little bit. And that tells us that it's actually happening faster to our statin group than it's happening to our no statin group. So this is the percent of cohort without the outcome. Without the outcome over the number of days. So that's pretty straightforward. Let me know if you have any questions about that. It can be quite confusing, but is actually very valuable to use. Just to show you, here's an example from a study that's a little more interesting. So here's their Kaplan-Meier. So on day 1, 0% of the people had been given this set of drugs, and 0% of people had not been given that set of drugs. However, and so we want to see their improved outcomes. I forgot what this study used as their metric for it. But basically, by the time you get out to 100 days, about, let's call it 55% of people, more than 50% of people have experienced this outcome, versus in your blue group over here, just about 25 or 35% have experienced it. So this gap over here is the gap in the amount of people who have experienced it on this same exact day, the percentage of people who experienced it on that day. So this is telling us a lot about time, how long it takes for these events to unfold, and what's going on with them. And you can see over here, if I was them, would cut it at about 180 days, because you can see there's no real difference. There's a drop off here indicating that a number of people fall out of the study for one reason or another, but there's no real, they pretty much parallel each other, and there's no real change in percentages. So if you see something like this with this flat line, it means you can feel free to go back to your time frame in your study and cut it at like 180 days or like 200 days and capture whoever's out here a little bit. But that could be a way to increase the temporal accuracy of your study without dealing with all these other people, because nobody else is really experiencing that beyond there. Other metrics you get: the log rank test, the hazard ratio and proportionality. A log rank test compares whether survival curves differ between two cohorts by using a chi-square test, which is a test usually of consistency between the two numbers, how like they are on a given. So, on 80 days, score 1 and score 2, how consistent are they? Are they different? Are they similar? Your degrees of freedom, which aren't that useful here because it's always going to be 1. If you're comparing two cohorts, it's n-1 is the formula for degrees of freedom. So you're going to have a 1 for almost all of your studies on this little box here. But the p-value tests the null hypothesis that the curves are the same for the two groups. But since this is statistically significant, it tells us that the chi-square value here, and that the p-value of that chi-square is statistically significant, meaning that the survival curves are different from each other and not just by chance. So that's that curve. Also, we have the hazard ratio. Hazard ratio between cohorts is the rate at which patients in a cohort experience an outcome for the first time. So it's, if previously we've talked about how long it takes stuff, this is the rate, the number, and how they come in, how quickly two groups of people experience that event. So if the hazard rate is 2, in this case it's 1.8, but if it was 2, it would mean one group is experiencing the event twice as fast as the other. In this case, 1.8 times as fast as the other group. And the 95% confidence interval tells you what it thinks the best guess of 95% is between those two. So it could be as low as 1.7 or as high as 2. Your proportionality metrics tests if the hazard rates follow the same trend over time and differ only by some constant factor. So how likely the two trend lines are the same. In this case, based on the chi-square value of the two trend lines, they're very statistically dissimilar. So you can be sure that your hypothesis is probably your null hypothesis is disproved. So I won't bore you. I know we're coming up on time, but I do want to mention, what if survival means death, right? What if you're actually looking at mortality events in your study? So here I looked at mortality for our no statin versus statin group, and guess what? The people across their lifespan in the health record, the no statin group dies sooner than the statin group, at a rate of 1.3 times of the previous group. But that doesn't tell us how long that takes, right? All we know is that they do die. Well, sure, everybody's going to die eventually of something. How long does it take, though, right? So from the time our folks enter the study, you can see here that our purple no statin groups are going down more steeply than our green groups, our teal group, our statins group. We can look back at our numbers here and see that the chi-square is very different right? That our log rank test is different. Our hazard ratio that the people in the no statin group are dying at 1.48 the rate, so almost 1.5 times as fast. And that the groups are very different in terms like this curve, these curves are different from each other. They're not by accident that it looks this way. There's something going on. So these Kaplan-Meier curves can be very valuable in understanding your phenomenon and what's going on. Okay, so lots of questions I'm sure about Kaplan-Meier curves. There's a lot of great resources to learn about them, including within TriNetX. I just want to close out on our number of instances test on this phase. Setting the number of instances tells you how many times the thing has occurred in a person's record. And there's a couple ways you can program this to help you out. It doesn't really help us for us because once somebody has been diagnosed with Alzheimer's in our group, we don't really care how many times, like just once is enough, right? Same with amputations or something like that, or particular kinds of surgeries. One time is enough, right? Or mortality. Setting it for however, with this, you can set, let's imagine you were looking at how many times, if your outcome measure was somebody being prescribed an antibiotic. Well, you could look at it and ask it to tell you how many daily doses a person got you. If you set this by date, it's going to tell you, for example, if they had 10 daily doses of antibiotics in a 14-day hospital stay, that would be 14 instances, right? Because it doesn't matter how many doses they get every day, you want to know how many days they had those. Similarly, on this little thing where it says date over here and visit over there, if you select this, what you'll get is for visit, it's the number of unique instances that occurred in one visit, like whether it's inpatient or hospital. So if a person came in and they were on a 14-day hospital stay and they had 10 daily doses of antibiotics across those 14 days, I actually didn't think that they should have, that would count as one instance in here, right? Because it's one order or one event. By the way, I don't mean 10 times daily doses, but once a day for 10 days is 14 instances. In this case, we would have once a day for 14 days would still be one instance. So something to think about. But that can be really useful. In this case, numbers weren't that useful for me, but medications, procedures, those kinds of things can be very valuable in terms of finding out how many times and how far out from the index event, in this case, 10, 11, 12, 15, 21 days did this occur. You can see here it also runs some nice numbers for you. For example, if you wanted to know the number of times that drugs were given or something like that, you can get the median or the mean of those, as well as a t-test of the number of times those things occurred. So not super useful for this study, but might be useful for your study if you're doing something that has those functions. So thank you for your patience. We're coming to the end, but now that we've spent weeks talking about this, think about this, going over this, to what degree we can actually start to answer some of our hypotheses. To what degree do statins impact people's odds of developing Alzheimer's disease? Well, our first hypothesis, our null hypothesis, is that it's not associated with any changes in likelihood of development of Alzheimer's disease, which we were able to demonstrate may be false. We may have found that that is not the case. And similarly, statin use is associated with lower likelihood of developing Alzheimer's disease. True. So this is great because this comports with the existing research. It's great if we also disprove existing research, but that requires a higher evidentiary burden and a higher degree of care in our analysis to get where we want to go. But in this case, it comports with it. It reinforces what we know and also adds some additional knowledge to it in terms of time. We could go back, look at time on treatment. So I could run this again and create two cohorts, a statin, no statin group on 10 years of statins versus who'd already been on it for 10 years and see how things fare for them. Maybe it's different, and we would find out that time on treatment negatively impacts Alzheimer's disease. Similarly, we could look at dosage, see whether it's 5 or 10 milligrams of a statin makes a difference in the prescription. And we could see how long people go for that and whether there's an interaction between dosage and time on treatment that impacts them. But for now, I'm pretty happy with finding this little nugget of information in here, and I'm excited to move forward with next week, where we're going to start looking at how to display this information in a way on a poster, for example, that people are going to care about, that'll actually be able to communicate that information to them. So I'm putting that together, and I will take everybody through that next week in a much shorter session than we've had so far. I want to show you one last cool feature. This is totally useful that I've been able to use here for a couple of different things, and that's to output your Word docs or your outcomes to a Word doc. And I'm going to actually do that, sorry, in the background as we are talking. Sorry, close my box for a sec. In the background, I'm going to run this, but basically it's possible in TriNetX to kind of dump all of your findings to a Word document that you can email around, that you can archive, that you can do a lot of stuff with. So first, you're going to go to your results function over underneath your outputs. That's where you get all of your nice little graphs. Sorry, I'm just waiting for mine to, I got logged out of TriNetX, so I'm waiting for it to log back in. But you can use this and you can save these data. So first you'll go to your results, then you'll go to your export all button over on the far right side next to your run function. And it's going to ask you a couple questions. First, what do you want to export to this function? Let me just do this right now while I can show you. You can see here in my export view, when you click on it up here at the top of your analysis, you see we're in our results. Here's my Alzheimer's results that we talked about earlier. When you output this, you can select. You don't have to include everything in here. For example, I don't want to include everything. I want to just include my Alzheimer's data, and I just want to include my Kaplan-Meier data, and I want to include my mortality data, all the demyelinating ones. I wasn't, that interested in them. They're too general, they're too broad, they're not really doing the job. So I'm going to export this, and then you can select export to a Word doc, a Word document here. And I'm going to download that. And while that's downloading, I can show you the next phase. As I said, this tool allows you to send your results to your mentors and partners, save them as a snapshot of your study for later use. And you don't have to keep referring back to the website and logging in and getting into your page and blah, blah, blah. It really just makes life a lot easier. So I'm going to save my document to my desktop here, and I'm going to fire it up really quick. So this is really handy, and I'm going to take you through what's included in here. First, it outputs all of your criteria for your cohorts, like your demographics, your diagnoses, your labs, your medications. It outputs all of that to the Word document. It also outputs the logic. What was included? Must have this, cannot have that. All of those things get included in here in a nice, easy to save and archive Word document. So must have any of these medications, cannot have any of these medications in cohort 1. Similarly, it also has, by the way, just some boilerplate information you might find interesting about what these data mean. It has like a kind of a generic explanation of what's going on in the data, in the document. But what you'll also find is, let me get my annotation cleared really quickly. What you're also going to find is that there's basically a clone, a Word doc clone version of your main measures of association table right in the Word document. And it's going to be great because you can do things like copy and paste. That's not on the roll. You can do things like copy and paste. You can copy this whole set of your table into an Excel sheet and then use it to regraph your data if you want. You can copy and paste in several tables together to make life easier in your analysis later. But yeah, it really helps a lot with that. electronics. So yeah, really valuable. Another thing that I recommend taking a look at is in the outputted Word document is your Appendix A through C. You can see here's all my outcomes, just the ones I selected. I wanted Alzheimer's and I wanted mortality there, so those show up. And you can see it's also got, by the way, my Kaplan-Meier curve is a drawing that's its output right here. But this is what I'm talking about with your text representation of the cohorts. So cohort 1, which is no statin by no comorbidities. All the patients must have had these things, cannot have these things. And here's the big stack of things. But what's really great about this is you can see here, it includes all of your ICD-10 codes. So what's super nice about that is it preserves your recipe. So once you've started a project, if you need to hand it off to people, they can use this to copy and paste and reconstruct in a couple of minutes exactly what you did for your study. You can also see in here that it has the analysis, exactly what you did in your analysis, so somebody can recreate it. And then it has a representation of the outcome definition. So what was it you were looking for? Well, cohort 1 was people who have a code of G30. Cohort 2 is G35 to G37, which is demyelinating diseases. And then 31 and 32 in a different group, along with 30 and 20 for all of these. So that is the Word document. It's super valuable and also, pretty usable. And like I said, you can save this to your hard drive so you don't have to worry about losing any of your information. So we are at the end of our time. Thank you for the amount of time we've gone over. I much appreciate your patience. Next time we've completed our objectives. You all, having watched the videos and gone through all this, can navigate the TriNetX interface. You can identify worthwhile projects. You can compare outcomes between patient cohorts really carefully. And you can use propensity score matching to reduce confounders. So after having done all of this, you should be in a good spot to get your paper ready for peer review or for conference submission or research letter or whatever you might be looking for. So our final session, I've got a question coming up in just a sec. We've got we know how to use the TriNetX interface. We have our confounders and our propensity score matching. We have our outcomes. And so we are ready to produce our final presentation. We're going to talk about getting your analysis key features into one place, arranging the information onto a poster, and writing up an abstract and what that could look like. So yes, we have a question. If you want to unmute and just go for it and ask.